Good morning, ladies and gentlemen. First of all, I'd like to apologize for not able to be with you during these the morning sessions was feeling a little bit unwell. So just want to share with my presentations for abdominal POCUS in the recording form. Really, I'm very sorry for the inconveniences. So basically, we're going to start on the abdominal POCUS, and bear in mind that abdominal POCUS is sometimes a bit technical challenge, and it take time to learn. Whatever I show you today, it will give you some idea. So how can POCUS help you in the day-to-day practice, especially in terms of abdominal POCUS? So this is the outline. So first of all, we need to know the probe and the scan technique, and then followed by the normal and abdominal scan. So the abdominal scan, basically looking at the thing that I listed here, and finally going to share three cases. So before you start, you need to know what probe you can use. Okay, so you have a linear probe here. Yeah, can see the superficial structure very well. Phased array also you can use. You can especially for a deeper structure. Curvilinear or microconvex is also another probe that can be used. So basically, that you don't have much problem in whatever probe that you have. Yeah. So in terms of scanning technique is that there are two important scanning technique. First is a six-step target technique, and also a follow column technique. So we're going to go through one by one. Okay. First, now we're going to talk about the six-step target technique. So what you mean by six-step? So we first start with a transverse and a vertical substernal, right hypochondrial, left hypochondrial, suprapubic transverse, and vertical. So let's go step by step. So this is a transverse substernum, okay? And you look at the video, I'm going to show you. You put the probe transversely, okay? And then you can fan up and fan down, okay? Put probe transversely, fan up and fan down. So there's a mnemonics, what things that you are looking at. So if you look at this picture, you see the Playboy, then after that the tear fighter, and also the bullet, okay? All right. So let's go in one by one, okay? So first you see the Playboy sign first. So Playboy sign is basically you tilt the probe up, and then you're going to see the Playboy sign. So what the Playboy sign here means is basically is the hepatic vein. Huh? So this is a right hepatic, left hepatic, and the middle hepatic. Okay. So the importance of this is that this is where by sometimes you can see the IVC. What do you call that? This is the IVC, and sometimes you can see the tips of the UVC can come into here. So when you tilt the probe downward a little bit, you're going to see another structure which is like a tear fighter. It is like Star Wars tear fighter. So you can look at it carefully. Is that this is the structure that you're seeing? Okay, it's a H structure, although it doesn't come out in one screenshot. So this is where the so-called the portal vein situated. Huh? So this is a portal vein. Huh? Okay, so remember it is like a H pattern. Okay. So why is it portal vein is important is basically this is a place where you see the gas because the gas from the NEC will come into the portal the portal vein and then come into the portal in main portal vein, and then you could see that the gas coming in, huh? And you can see that the bubbly structure. So I hope you can imagine that this is the tear fighter. Okay. So when you flip the probe down, you're going to see this bullet structure. So this bullet structure is basically is a gallbladder. Okay. So what's the importance of looking at this gallbladder is basically you can look for gallbladder edema, especially when the patient who has severe sepsis. Huh? So you could see that here. So this is a nice thin rim of gallbladder. But if the gallbladder become thickened, the wall of the gallbladder become thickened. So this is a sign of capillary leak. Non-specific is a patient is sepsis. Okay, it can be appear like this. So what does it tell us is that so there is a significant capillary leak. See? So right, so to sum up, so you see the Playboy followed by the tear fighter and the bullet. Okay, you start again, right? Okay, so beginning now, okay, you see this is a Playboy. You flip down, and then you're going to see the tear fighter, and then followed by the bullet structure. So this is a bullet structure here. Okay, right. So this is a transverse substernum. And there's another one called vertical substernum. So basically what you do is that you turn the probe vertically, Okay. Then after that, you fan the probe to the right and to the left. Okay. So what are the important structure you want to see? Basically, you need to see the whales, and also a dragster. Okay. So now, what do you mean by the whales? Okay, so if you can, you can imagine with me, this is like the big head whale. Okay, the big head whale. So the nose of, and then this is the mouth. The mouth of the big head whale is basically a IVC. The nose of the big head whale here is basically the hepatic vein, and the eye here basically is a portal vein. Okay, so this is the substernum approach. Okay, so you tilt the probe to the right side. Okay, so you're going to see the structure here. Huh? So this is the aorta. Huh? So you can see the aorta, and then followed by the celiac artery and the SMA. So which is represent the tail of the dragster. Okay, so you can see here the artery, the descending abdominal aorta, and then the celiac artery and SMA. So what the important thing is here is you can look at the USC position. Okay. So if you tilt the probe, in order to look at the UVC much more clearer, you need to tilt the probe slightly at the inferior side, okay? And then if you manage to tilt the probe slightly inferiorly onto the right side, you could see that this is where its umbilical vein is, and then the portal sinus. This is the ductus venosus, okay? And then this is also the inferior vena cava. You can also imagine this is the whale, huh? Okay? So you can put a color Doppler here. Yeah, so you color Doppler here, okay? And this is another view that show you the UVC catheter is inside. So you can see that the part of the catheter here, and then entering now, you could only see the shadow, and the tips is at the atrial junction here. Okay, the IVC atrial junction here. So you can see the USC by looking at the dragster. Then you can see the USC. By looking at the whales, then you can see the UVC. Okay. So as we discussed yesterday, so you can actually adjust the UVC. You can see that this UVC is quite deep, right? So the best position is somewhere here. Okay, so it's whereby the inferior vena cava meet the atrium. So that is a perfect position. For example, for this catheter, the catheter actually did not go into the ductus venosus and did not go into the IVC. Huh? You see, it ended here, so it's corresponding to the X-ray here. Yeah, it didn't end into the atrium. Yeah. So at this view as well, okay, you can see the gallbladder edema if you could appreciate here. Huh? So this is a normal gallbladder here, okay, and then this is a edematous gallbladder. Remember, this is the whale's sign. Huh? You can see whale sign. So after that, you move the probe to the right side, okay, like this, okay, and then you fan around, okay, fan around right and left, okay. So what the thing that you're going to see is that first, this is a structure, the liver, the kidney. This is a diaphragm with a lung and adrenal gland. Okay. So to imagine a little bit with me. So you could imagine that this adrenal gland is like a lady squat down on the stone. Huh? So this lady is actually squat down on the stone. So what the important of this clinically is that the adrenal gland basically is telling us that whether because it's always sit on the kidney, so you can tell us whether the kidney is present or not. Okay, and this is also the left side. This is a spleen. Okay, this is a lung. Okay, right, and then this is a psoas muscle. So this is a kidney, and then also this you see the lady seated on top of that. Huh? So this is on the left side. Okay. Oh, so similar, left, right, also the same. You got the adrenal gland on top of the kidney. Okay. So if this ultrasound basically show you a slight dilatation of the pelvis, the pelvis calyces, which signify hydronephrosis. Okay, and remember the lady seated up, which is adrenal gland, seated on the kidney. So the kidney is there. So this picture also, there's a lady here sitting on the kidney. So this is a huge, large renal cyst over this side. And this is an example of the picture of polycystic kidney. You can see that the lady is there, okay? And then this is a multiple cystic component of the polycystic kidney. So remember, I mentioned about the lady. So when the lady sit down on the kidney with the folded legs, so the kidney is there. But if you could see that sometimes the adrenal gland just lie flat, like for example, like this lady. So because why they lie flat? Because there's no kidney there. So it's a very important telltale sign that when you have an adrenal gland which is lie flat, there is a very high potential of renal agenesis, and this is the psoas muscle. Okay. So then come down to the suprapubic area. Huh? So suprapubic area, we start with the transverse suprapubic region. Huh? So you fan up and down. So this is the area that you want to see the urinary bladder. Huh? So this is the urinary bladder with the rectum here. Okay. So beside doing a transverse scan, then you do a vertical scan. Huh? So this is a vertical scan. Turn the probe and then make sure marker upside, pointer upward. You're going to see the bladder. Okay. So, sometimes it's helpful is that we want to see that whether the patient do not pass urine. Want to see whether the patient do have urine retained in the bladder or not. Okay. So on top of that, this is a very good area to see ascites. Huh? You could see that this is a nice like distended bladder, and then there's a free fluid around it. Huh? Okay. So this is a transverse view, and then this is a vertical view. You could see that there's a free fluid around it. This is a bowel, and then this is a distended bladder. Okay. It's also very useful. Sometimes the patient do not have any urine, but although the CBD is inside too, so you could see that this is a Foley catheter in the child. So and you can see the large urinary bladder. So the problem is that it's a blocked CBD. Now let's start with the case first. Case number one, it's a 36-week newborn baby, IOGR birth weight 1.2 kilogram. He had blue very muffin rash. You noted abdomen appear to be full before the USC UVC insertion. And no urine output for the past 20 hours. So now the clinical question is that is the UVC USC in place? Is there any urine in the urinary bladder? Yeah. Are the kidney and liver normal for prognostication? Because you know that this child congenital infection, sometimes the liver and the kidney might have some pathology. So let's go to the step-by-step approach. Okay. So remember, these are the view that we see. First, we see the Playboy first. Playboy, then followed by the portal vein. The Playboy is a hepatic vein, and then the tear fighter, which is the portal vein. Okay, and also the bullet, which is your gallbladder. As you could see that the vein appear dilated, okay, or the hepatic vein appear dilated. And if you look at this, there's some abnormality here over the liver. There's some speckles or things over this side, okay. So these speckle things are rather fixed, okay. So this is basically speckle or calcification, okay. And you look at the portal vein, the portal vein do not have any gas inside, huh? So then the likelihood of acute NEC is less likely, huh? Okay, yeah, but it doesn't mean that you don't have. But then basically, if you could see the acute gas bubble here in this the tear fighter, then that is a very pathognomic of NEC. And you look at the gallbladder here. Gallbladder is slightly edema, it's slightly dilated, but there's no edema. Similarly, here you can see a speckle of calcification on this side. Okay, so from this view, you can say that okay, hepatic vein, portal vein, and then gallbladder relatively okay. But then you could see that there's some calcification, or there's some hyperechoic structure, which likely a calcification in this patient congenital infection as we tie through the clinical status. Okay. Then you move on to the vertical scanning because you had inserted UVC, USC. So this is the UVC. You could see that it come out all the way down into this the junction at the IVC and atrial junction. This is the best position. We don't want to go too deep. This is a good position. Similarly, you could see there's calcification here. And you tilt the probe laterally and you look for the Drexler sign. So this Drexler sign that you can see that this line Drexler with the celiac artery and then the SMA. You can see the USC here and the position is quite optimum, just above the diaphragm. Okay. And you go to the right hypochondria and left hypochondria. So these are the changes that you could see. This is the liver, okay, and then this is the kidney, this is the adrenal gland, and then this is the lung. As you can see that the lady is sitting on the kidney is present. And the thing you need to spot that is a bit different is that you can see that there's a lot of calcification, the hyperechoic structure in the kidney and also the liver. So basically this is a calcification over the kidney and the liver. On the left side, the the spleen and also the left kidney as well. So can see that some calcification, and the renal pelvis also slightly dilated. Okay, both sides as well. Okay. Suprapubically, you do a transverse and vertical, so they are look unremarkable. It's just that you could see that the bladder that they did have some the child did have some urine in the urinary bladder. So that is all about the basic scan view. Now we go to the basic bowel assessment. So this is a bit tricky because we want to teach you how to really assess it, but then have some basic knowledge and how the basic bowel assessment is done. So to see the basic bowel changes, you probably use this technique. It's a follow colon through technique. So whereby you do a sweep, like what is demonstrated here. Okay, sweep down on the other side. Okay. So so it is this kind of movement position. Okay, all right. So what you're going to see, okay. So these are the structure, the basic bowel structure that you see here. So we start from the stomach first. So this is the stomach. Over the you scan at the area of the stomach. Okay, probably we yeah, scan area of the stomach. So this is the whole stomach. You see that the lugae of the stomach. Okay, morning training to this. This is the pictures of the colon, okay, the large colon. The large colon is the important thing. You can see the hostra. So you can see, if you remember anatomically, this is a hostra. Okay. So the small intestine divided into two, ileum and jejunum. So ileum, the mucosa are rather smooth. You could see that, huh? This is a smooth mucosa. And then jejunum, usually they are multifold. Okay. You need to remember is that the image can be so nicely because there are certain degree of fluid in the abdomen, there's some degree of ascites. Then only you could appreciate them very nicely, like I illustrated here. So the abdominal adrenal scan that we're going to see is all this structure, the bowel dilatation, ascites, bowel mobility, perfusion, thickness, and also the abnormal gas. Let's go in one by one. Basically, this is a normal bowel appearance. As you could see that you can just see a lump of guts, okay? It is not that clear, yeah? As compared to the earlier picture that I showed you, you could see the hostra, you can see the jejunum, you can see the ileum. But basically, because there are some degree of ascites, then only you can appreciate it nicely. Over this side, you could see that, oh, this is basically a true bowel images because they are filled with gas and filled with some stool. And you could see that the gut is mobile because it is an mobility. So this is another view. They do not have any clear ascites, so that's why the images is not as nice. So it's compared to the normal and the dilated bowel. So this is a patient with a dilated bowel. You could see that you can see that the gastric content very nicely, and then the structure of the bowel very nicely because they are filled with a lot of fluids. Okay, so that's why it dilated. Then hence you can see the image very nicely. Okay. Over here, because there are some filled with gas and some filled with small amount of stool, they are not dilated. Hence, you can't see anything much. So this is another comparison or another bowel ultrasound. You could see that, oh, these are bowel are dilated, okay, very much dilated with fluid fill. And you hardly see any mobility as compared to here. You can really appreciate some mobility, yeah. So free in the abdomen. So these two images shown here is that, so sometimes the ascites can be very clear. Okay, so when the ascites is clear, you're less worrying, because the fluid inside are relatively, so hopefully it's a clean one. So this is a bladder, this is a uterus. Okay, so as compared to here, yes, there's fluid, but the fluid over here is very cloudy. You can see that it moves in and out when you press the abdomen. So comparing these two, yeah, cloudy and clear ascites. Other thing is that we look at the bowel mobility and the perfusion. As you could see that here over this side, you notice that the bowel are very active, pushing in and out. Okay, and we put in the color Doppler here. You could see that, oh, the color is very striking. So these are all abnormal signs. Meaning, what does it mean? It means that the bowel is dilated and has some sign of hyperinflammation. The perfusion are very striking. As compared to here, you hardly could see any bowel movement here, okay? And you put a color Doppler here, you can't see any perfusion. So yeah, so this is a inflamed bowel. Probably this is a relatively bowel that without mobility and poor perfusion, likely dead bowel. Other important thing people are always mentioning is the intestinal signature. So the intestinal signature basically it is 5 layer. So started with outer layer, selosa, muscularis propria, submucosa, and muscularis mucosa and mucosa. So this from outside hyperechoic, hypoechoic, hyperechoic, hypoechoic. Yeah. So as you could see here, probably not very clear. You can see there's multiple layer here. Yeah. But this is just nice to know. Yeah. But we are not going to very deep in this. Yeah. So what our major concern is that whether the bowel is thickened or not. Okay. So to compare these two, yeah, so this is a relatively thin bowel and compared to another here, so this is a very relatively thick bowel. So the thickness, I think matter the most, rather than the small bowel, so-called the intestinal signature, the different lining. Okay, yeah. So over this side, if you measure the bowel thickness, okay, it's about 2 millimeter. So the normal bowel wall thickness is supposed to be less than 2.6 millimeter. Okay. So if you compare to the earlier scan, so this is the child with the thickened bowel. If you measure them, the bowel is thickened, is more than 2.6. So this is an abnormal bowel. Okay. So now let's see guts, air in the guts. So our normal intestine will fill with air. So as you could see here, as I explained earlier, if you have some ascites in the gut, in the peritoneum, you can see the structure much better. So and why you say that this is a gas in the gut, as you could see here, is that you follow the bowel. Okay, so for example here, you could see that there's a bowel here, and then the gas is limit in to the bowel, inside the bowel, as you could see here. So the gas is within this bowel, within this bowel. So similarly here, within this bowel. Outside of it, okay, the ascites fluid here, you can't see any air shadowing, air shadowing. Now let's see what is the gas outside the guts look like, So remember, this is the liver, okay? So this is the peritoneal cavity. This is the place whereby it's supposed to be ascites. So this air structure do not confine in the gut. Yeah, so it is a gas outside the gut, Similarly here, so you could see that this is a liver, so this is a gas outside it, because you could see that it's like a ultrasound lung, It's like a curtain sign like that, So when you press in and out, it's like blowing gases into the area above the liver and in between the liver and the diaphragm, which not supposed to be have any air. Okay. So remember other things that once a gut filled with gas, so sometimes they will travel. Where they follow the portal vein. So remember, this is the part of the portal vein. So you could see that the gases are coming from the portal vein into the liver. Similarly here, it's like a train of gases travel from here, go all the way up, and then causing some gas embolism in the liver. So these are the bowel, ultrasound abdomen bowel. So this is the dilated bowel. That's how we talk about it. And then you could see that the hyperechoic structure surrounded the bowel wall. And intermittently, you can see that there's some gas bubbling through. Similarly here, there's gas at the bowel wall. And you should see that some shooting star here. This shooting star basically gas travel along the wall into the portal vein. Yeah. So now come to this case number 2. It's a day 8 of life. A child unfortunately missed in perforated anus with a tiny fistula. Presented with abdominal distension. They refer from district hospital for intestinal obstruction. And child was hypotensive upon arrival to PICU. So this is the X-ray that done at the district hospital. At this moment of time, the doctor, the referring doctor, saying that the child abdomen is distended but rather soft, no discoloration, right? And there's no sign of perforation here in this abdominal X-ray. But upon arrival to PICU, noted that this child is hypotensive, and this is the color of the patient. So now we want to have a specific question to see whether there is a bowel perforation or not. So then we do an ultrasound abdomen. So this is the bowel ultrasound abdomen that you see. So remember, this is the right hypochondria, whereby you can see the adrenal gland, the kidney, and the liver. You could see that here there's some fluid collection here. The zip collection can move. in and out. Okay, and then this is the lower part of it. There you can see that some free fluid around the guts. Okay, and then this is a kidney. And do a transverse view over the abdomen, and you can see that, yep, so this is the liver, and then this is a free gas, as we see just now, huh? The free in between the diaphragm and the liver, and then you can see that free fluid outside, huh? And then this is another view. You could see that this is a jejunum. You can see there's the lining there, and you can see the fluid, this ascites fluid, and then this is a free gas, huh? This free gas did not it's not inside the gut, it's actually outside. Huh? So you could see that there's a free gas outside. And then we know the diagnosis already. This child had perforated guts. Yeah, hence we inform the surgeon. The surgeon kind enough to insert the drain, and then without even call in the radiologist. Yeah, so this is the drain. Now, case number 3, we have a 1-month-old baby presented with vomiting with abdomen distension in shock. His murmur heard and an echo showed COA and VSD. He was started on prostin and he resuscitated and dialyzed, and we started feeding very early, day 3, and go full feeding very fast, and abdomen become very distended. Okay, so now we had to question why the abdomen distended. Very unfortunately, this is the same child, the child that you have NEC. Huh? So you look at the tear fighter. Remember the tear fighter here? Yeah, you can see that the gas flowing through. Okay, and then this is a multiple Starley sky appearance whereby you get gas embolism, and then the gas inside the portal vein. Yeah. And it is a nice pneumatosteal intestinalis, okay, or very bright, very bright gut. Huh? Bear in mind again and again, so this is some gas, there's some fluid that only the anomaly can see very clearly. So this child basically have gas embolism, yeah, and then he underlying cardiac problem. So the gas not only go in the liver, start in the liver, it also travel down, and then into the venous system. I could see here the travel down into the venous system. Yeah, the nice gas travel, not nice. I mean, not nice for the patient, but it's, the images that created, it can be clearly seen, with the gas moving in and out. Okay. So not only that, the gas also travel to the brain because the child has a VSD. Huh? So here, this is a transverse view of the scan. You can see that it traveled the middle cerebral artery territory, anterior cerebral artery territory, okay, posterior cerebral artery territory, okay, and the middle cerebral artery territory. Yeah, and you could see that there's some bleeding as well. Huh? The bleeding over the brainstem, or over the thalamus area. So hopefully that this is a quick overview of ultrasound abdomen, that we continue to a step-by-step approach on how to do the abdominal ultrasound, and also some abnormality you can see. So as I say, abdominal ultrasound as a POCUS provider is a bit challenge, but uh, the most of the image can be seen with ascites, and then we can yeah, then only can see the power more clearly. Yeah. Once again, very sorry that I'm not able to uh, uh, join the meeting. I hope that you can enjoy the rest of the meeting. Thank you very much. Yeah.